I'm going to go ahead and put the presentation up. I know there were quite a few of you in our previous lecture here, so welcome. We are recording this today for those that could not make it or those that would like to review the information. I'll be posting instructions for you in the chat area as well. I'm also going to post the link to the handout for you in case you did not get our email earlier today. Okay, there we go. All right, everyone, welcome again. I'm going to give you just a minute because I know a few of you were just on the other class. I'm Dr. Rolling. I'm a public health dentist here in Phoenix, Arizona, and I was the former chief for the Office of Oral Health for Maricopa County's Public Health Department. And if you were in the last session, you know I'm also a recent C. difficile survivor that followed a dental visit and antibiotics prescribed just in case. I'm talking to you today in a couple of our sessions about improving your infection control and protocol in your practices. And UVC technology was a technology that we had quite a few questions about in some of our other classes. So Surfacide today has generously sponsored this portion. And after my portion, we have Danny Young, who is in charge of the dental world for Surfacide, who will be coming on and also presenting her portion to give you more details about the technology. So I'm here to give you an overview of UVC technology. Alexa, this session is for anyone that would like to attend in the dental world. So you're in the right place. And welcome again, everyone, for joining us. And this is recorded for on-demand viewing. Okay, so UVC technology, a new paradigm for improved infection control in the dental practice. And actually, UVC technology and UV technology has been around for quite a while, even in healthcare. But we don't see it that much in our dental practices. Now, it started to get some press after we were all shut down and then reopened after the early days of COVID-19. And so we were all sort of scrambling, what could we do to upgrade our infection control? And of course, we're worried about aerosol as well, not just surfaces, but aerosol. And so UVC is one of these technologies that resurfaced, if you will, in dentistry. Okay, my conflict of interest and financial disclosure. Again, this webinar is sponsored by Surfacide. I am the Chief Education Officer here at Dental CE Academy and an employee here. I have not received a speaker's honorarium and I have no financial affiliation with Surfacide. Our learning objectives today hopefully understand the history of UVC light and technology, describe the mechanism of action of UVC disinfection, and discuss uses of UVC technology in healthcare settings. So for years, UV technology has been used to kill bacteria in the water, in the air, in the environment. It was recently recognized and developed as evidence-based, highly effective surface decontamination in hospitals and medical facilities, including dental practices. And UVC light in the form of germicidal lamps has been used since the late 1800s, actually, to kill many types of microbes that typically cause indoor air quality problems. Bacteria, mold, yeast, viruses. Tuberculosis was a huge, huge problem And we'll see it was actually used for that purpose too. So UVC was actually used to disinfect the municipal water supply of Marseille, France in 1908. Now, I always like to look at the history of things because it sometimes will make better sense out of what's going on today. But in 1877, the British physiologist Arthur Downes and scientist Thomas B. Blunt put solution-filled test tubes outside in the sun to be irradiated, and they discovered that sunlight could kill and inhibit the development of pathogenic bacteria. And light is pretty amazing. We know we use light in other forms in dentistry. Photobiomodulation would be one of those, where we use light to help speed up healing, inflammation, also known as low-level laser or cold laser, but now can be performed with LED devices that are FDA approved for that purpose. So we know that light does exist to help in healing and kill microbes. Niels Ryberg Finsen, 1860 to 1904, was the first to use UV rays in treating disease, and he was awarded the Nobel Prize for Medicine in 1903. He invented the Finsen curative lamp, and it was used successfully through the 1950s. So imagine, here's something that somebody was awarded the Nobel Prize in 1903 for. And in dentistry, really, we haven't used UVC as much as we could or should. Westinghouse developed the first commercial UVC germicidal lamps during the 1930s, and those were used primarily in hospitals at the time. You know, Westinghouse on the East Coast was also an electric company, so they were very involved in lighting and research and so forth. And then UVC was used for sterilizing the air to improve air quality in hospitals, also kitchens, used in meat storage and processing and packing plants, even the blades of those plants. I saw bakeries, breweries, dairies, beverage production, pharmaceutical plants, and animal labs, anywhere microbiological contamination is a concern. And again, if you jumped on a little bit late here, be sure to download the instructions for the day. They were also emailed earlier today, and you'll see a link in the chat area to the symposium and handouts. If you tap on that, you'll be able to access the handouts for the whole day, as well as instructions for CE credit, which I know are very important. So during the 1950s, UVC was incorporated into air handling equipment. And it became a major component in the control and eradication of tuberculosis. And we saw that happen again in around the 1970s. What happened in the 1970s? Air conditioning. There was an outbreak of Legionnaire's disease. And Legionnaire, because of this outbreak, at first, they weren't sure what was going on. They did not connect it to the air conditioner. And they were the filters and the condensers, they were dirty, they had not been cleaned. And so it was infecting people. And, it's interesting when we think about our dental practices and the amount of aerosol that we generate every day, which is a phenomenal amount, and we're immersed in it. It doesn't just go away when we walk out of the operatory. It's still there. So it's important to me that I think we understand more and recognize that, and why it's so important to really consider UVC light in our practices, because we can't reach all areas, and we have to address the aerosol in some way, not just in mitigation, but what is left with the smaller particles that are still floating around in the operatory that can be sent down the hall or out to the reception area and vice versa. If you have any questions, be sure to type them into the chat area. Now, there was a shift in the 1960s because there became a decrease around the concern about microbes and infection. Why? There were new antibiotics, new drugs that came onto the market, which, by the way, many of them are no longer working because of antimicrobial resistance. Disinfectants that were developed, and sterilizers, autoclaves, etc. So the UVC was sort of put on the back burner a little bit, and these other technologies and antimicrobials took their place in terms of use because the concern had decreased. But now we have a real problem here, and I will be talking about this in the last session today on superbugs, antimicrobial resistance, and Dr. Goff is going to be talking to you. She's the expert at 12 o'clock today about the new antibiotic guidance, and she's going to address antimicrobial resistance and antibiotic stewardship as well. But we're running out of antibiotics, and antibiotics that we used to be able to use for the treatment of pneumonia, for instance, may no longer be working. In my case, I had a C. difficile infection, and I failed 4 rounds of antibiotics. I had a resistant strain. So when you are not able to be cured with antibiotics, what happens? You die. Okay, these are infections that can take over your body and you die. And so this has now hit the wall in terms of what we're going to be able to do to treat our patients. And the number one thing that we have to do is antibiotic stewardship. We have to prescribe antibiotics when appropriate. That's where we need to start, and infection control. So hence our presentation today. So UV light, where is it found? In sunlight, emitted by electric arcs, and it includes what reaches us here on Earth from the sun, and those waves that don't reach us, which we'll talk about. And so classified as non-ionizing radiation. So how does UV light work? It causes photochemical changes within the microbes or microorganisms. The UVC energy is absorbed by the genetic material of the cell, the RNA and the DNA, and it disrupts those nucleotide bonds, and in some cases will form thymidine dimers, which when Danny joins us here, we'll also talk about that. And thymidine dimers have been implicated in sun cancer or skin cancer and so forth. 2 conditions have to be met, though. Radiation of sufficient energy to alter these chemical bonds must be available, and radiation must be absorbed by the target molecule or microorganism. Now, we know there are technologies that are being used, not here in the US because they're not FDA approved, but you can actually use a dye to help with that targeting and light therapy. Photodynamic therapy is one of those, PDT, which is used in Europe and I believe South America, but not FDA approved here. So changing the target molecule some way so it's more receptive to the UV light. What about UV light effect on viruses? And this is a study. UV light germicidal effectiveness and use, again, is influenced by what? Organic matter, wavelength, the type of suspension, the temperature, the type of microorganisms, and then UV intensity. So in order to effectively kill a virus, UVC light must be emitted in a range of 200 to 280 nanometers. And that has the potential to do real harm, not good harm, but also bad harm. Now, Danny will talk to you that they believe around the 240 nanometers is considered ideal. UV spectrum. So UV spectrum, UV light across the spectrum can exert many effects that are beneficial, but also damaging to human health. And this is the electromagnetic spectrum. So X-rays, which we're all familiar with, are down around 100 nanometers. And as we move up, ultraviolet, 200, 280, 315, 400. UVC, you can see, is towards the lower end of that, between the 200 and 280. Visible light, which we're all familiar with, you walk outside, but infrared. So when you look up here at this red light spectrum here, from about 600 nanometers up to 930, sometimes 1030, those are the wavelengths that are used in photobiomodulation. And if you're not familiar with photobiomodulation, there's actually a course on our website tomorrow morning, Saturday, with Dr. Praveen Irani out of the University of Buffalo, who is an international researcher on photobiomodulation and being used in dentistry to improve inflammation, speed up healing, reduce dry sockets, used for pain management, swelling, edema, and so forth. So great class tomorrow. Just go to the website and you'll see the link for that. When you get up to IR, you're not going to necessarily see that, right? It goes past the 780. And tomorrow's presentation, a developer of one of these photo biomodulation devices will demonstrate that. You'll see it light up at about the 606 nanometers, I think, or 660. But when you get up to the 930 range and higher, you don't see the wavelength anymore because it's not visible to your eye. Okay, so ultraviolet radiation, ultraviolet A, wavelengths between 320 and 400 nanometers, which we saw here. And then ultraviolet B, radiation between 290 and 320. And as we said, UVC, ultraviolet C, these are wavelengths, shorter wavelengths than that of the violet end of the spectrum. So wavelengths of 4 to 400 nanometers, so somewhere between 200 and 290. And Danny will talk to you about that 240 being the sweet spot. So differences here, UVA and UVB light. This is what causes sunburns, right? So you get sunscreen out there and it'll say it's effective against UVA and hopefully UVB. And why are we worried about sun and sun exposure is because it can cause premature aging, but also associated with the development of skin cancer. So sunscreen, I live here in Phoenix. I live in sunscreen and UV protective clothing, etc. UVC light has the most energy of all three types, but it's the most harmful. And usually it doesn't reach the Earth's surface because it's absorbed by our atmosphere. But it can be man-made with devices to do the good of infection control and mitigation for microbes and so forth. But it has to be used safely, which Danny will discuss, and not in the presence of humans or animals. So you aren't going to be in a room when UVC germicidal radiation is taking place for disinfection. And many of those devices will have safety features, which she will talk about. They may switch off if somebody walks in the room. There are apps, etc. Now, ultraviolet environmental disinfection, UV, the problem here that we know is that hospital-acquired infections, we have to be concerned about superbug contamination, and not just in hospitals, but also outpatient settings, medical practices, dental practices. Your patients don't walk in resistant to antibiotics. It's the bacteria that they come into contact with that is resistant, right? In my case, I had not taken an antibiotic in 13 years, and I don't take any medications on a normal basis. But I somehow came into contact with a hypervirulent strain of C. difficile that was resistant to antibiotics. It was the germ that I unfortunately met, right? So that's what we have to be concerned about. We have to be concerned about, is our infection control practices enough? Are they enough Do we have contamination remaining on our counters or our units? If you are using the wipes that we were just talking about in the C. diff course that are quaternary ammonium wipes, they are not sporicidal. So you're leaving some stuff behind. Multi-drug resistant organisms we're concerned about. Clostridium difficile and others are thought to be transmitted to patients through contaminated surfaces, fomites, clothing, aerosol. We have to address every patient using what? Standard precautions. So every patient must be addressed as potentially infectious. I've had dentists that have asked me, well, how would C. diff get into my dental practice? Well, because it's everywhere. It's on the soles of shoes. We have to be prepared, hope for the best, but be prepared for the worst. Those would be administrative controls. How would TB get into your dental practice? We are mitigating for TB, hopefully. How would COVID get into your practice? These are all this one and the same. So we have to be prepared for the fact that dentistry is procedural. All day long, we are performing these procedures really like mini surgeries. We're generating aerosol more than any other profession out there. That aerosol contaminates the surfaces, whether they're environmental surfaces or clinical surfaces, and that aerosol doesn't just stay put in the operatory. And when you have the very small particles that are generated, those can remain suspended in the operatories and anywhere in the practice for several hours. And they can be picked up by microcurrents, somebody walking by, etc. So it's important that we are able to address this in a way that's effective and understand that we have a role to play here, that just using wipes in our operatory is not enough. This was a Westchester Hospital study, Clostridium difficile infections before and during use of ultraviolet disinfection, and it was from 2015. But this particular hospital experienced a 70% decrease in hospital-acquired C. diff infection rates in its adult ICU. Hospitals are battling C. difficile, so they're constantly using and looking for technology, because if a patient is harmed by C. diff while they're in their hospital, it's expensive to the hospital. It affects their reimbursement rate. People are going to stop going to that hospital. Now, I know many of you are out there saying, well, that's a hospital. We're a dental practice. So does that really pertain to us? We're a dental practice. Well, yeah, it does. Because your patients are coming to you with the trust that you're doing everything you can to protect them, and that you've implemented everything you can in terms of your infection control. And when you can show to them and demonstrate to them that you are advanced in your training, that it's important to you, you demonstrate that on your social media, that you're using technologies that are state of the art to protect them and your staff, that goes a lot further than the little goodie bag with the toothbrush and the toothpaste. They want to know that they're in your practice and it's safe to be there. Question here, this study, does ultraviolet radiation exhibit antimicrobial effect against oral pathogens attached on various dental implant surfaces? This was a systematic review. And they looked at UV radiation on dental implant surfaces, and they found that a significant antibacterial effect was demonstrated through a reduction in bacterial attachment, biofilm formation with suppression of bacterial growth. And again, this is not the tell-all of studies. There are other studies out there, but it does demonstrate, and this was from 2022, so very recently, that UV radiation is effective and maybe it should be considered in our implant practices. Another study here that was published in the Journal of Public Health in Africa, 2019, potential benefits and harms of the use of UV radiation in the transmission of tuberculosis in South African health facilities. And these were experimental studies, although we know they have proved beyond any reasonable doubt that under controlled and maintained conditions, they were looking at mycoplasma tuberculosis in this situation, can be prevented using UV radiation. They felt the key question still remained that there is a need to demonstrate the role of UVGI in the background of the pyramid of controls to prevent healthcare-associated TB infection. So they believe this is just scratching the surface. And again, more studies should be considered. All right, I'm going to go ahead and take your questions, and then we're going to have Danny log in. Go ahead and type your questions into the chat area. I see a few here. Okay. And if I don't get to all of your questions today, you can always reach me out through the website here. So question about, will UV technology kill C. diff spores? So we know that UV technology does, in some cases, kill C. diff spores. Not all UV technology is alike. Now, Danny will tell you that in their case, they are awaiting, I guess, some sort of FDA emergency use only. She can talk to you about that in more detail. But understand that if you get on Amazon today and you look at UV technology out there, they're not all the same. So you may see some that are purported to treat your electronics. There's one that you can get for your cell phone. It's called phone soap. You might have seen. That's not necessarily going to kill C. diff. And if you read it, it will give a very good overview of what it claims to be effective on. Okay, thanks for that question, Carla. Question from Donna, how long of an exposure to UVC light is effective? No ozone should ever be inhaled into the lungs. Poor outcome. It depends on the device itself, and we're going to have Danny break that down for you. So again, some devices, and that goes really for any light emitting device. It has to do with power as well as time. Nicole wants to know, what is the percentage of dental offices currently using this technology in practice? And if so, what is their feedback? So we're actually going to be talking about that in just a short minute with Danny. So I'm going to show you, I'm going to start this portion off with a video. And let me make sure that I've got all the questions here. How would I rate ozone units? You know, Dr. Volchnak, I've read quite a bit about them. I have no rating myself. I know that the Holistic Dentistry Association, many of them are using ozone. We had a pediatric dentist here a few months ago. I have not used ozone myself, so I can't talk about it with any sort of familiarity, unfortunately. Okay, I've got your questions, I think, here. Let me go ahead. I'm going to show you a brief video, and then Danny will come on. We'll have her presentation up here for you. Okay, I'm going to be on mute, so there's no echo. Danny's ready to go. Let's show you the video, and then we'll move forward.
Okay, wonderful. Can
Welcome.
you hear me okay?
We can hear you, and I gave them sort of your brief introduction early on, but I'd like to thank you and Surfacide for being here today. We really, really appreciate it. And I did let them know that you're the dental go-to person. So they're going to get your information with any of the deep dive questions that they have. I'm going to go ahead and turn it over to you, and I'll be here in the background.
Sure. Okay. Well, I already see a lot of questions coming through, and thank you for those questions. I will get to answering all of those. But to start off, my name is Danny, and yes, I work with Surfacide. I'm based out of Minneapolis. You can see some snow behind me, so hope everybody's staying warm. Um, but the biggest thing here is that so what we know, and the reason that UV technology is being a little bit more highly accepted in the dental practices and outside of just hospital settings in general, is because even the science shows that even in an OR, in a what's supposed to be a sterile environment for surgeries, things like that, 50% of high touch surfaces are not fully clean during a terminal clean. And that's not even including something that is maybe a dirty case, or if there's a quicker turnaround, something like that. And the reason being is not because of any lack of effort or even the good job that our environmental services team members or your guys' staff are doing. It's simply because we're using wipes longer than they should. We're not giving them the amount of dry time that we should. A lot of times, actually, by using wipes and chemicals, we're actually re-aerosolizing a lot of the things that have landed on those surfaces, and then they come back down later and land on more surfaces afterwards, just able to recolonize. So this is why UV has become something that has been a little bit more interesting in the recent years, mostly because it can do everything from the air column all the way down to the ground. Now, I did see a number of questions about technology in general. So the video that you guys saw is of our most common technology, which is a tower, but we can do everything from light inserts into the ceiling that are constantly filtering air. You can do it in keyboards, these big towers. I mean, we have no shortage of technologies that can be fit into every sort of practice and are all safe and have a number of safety protocols around them. So I will get into all of that, but I don't want you guys to think that we're just limited to this tower, although that is our most common. So Kirsten talked about it briefly, but I do want to let you guys know that the FDA has approved all UV devices right now in the US. The EPA actually regulates UVC disinfection modalities, and the FDA is going through a review process of that right now. So there is a limit to what I can discuss. I saw a question about C. diff come up, and just to let you know, I cannot specifically go into the data of C. diff. But I can tell you that there is a lot of data out there on it. If that is something that you would like to learn more about, I can put you in touch with our Office of Medical Affairs, and they can have peer-to-peer review or peer-to-peer discussions with you. Just as myself, as we're going through this process, I cannot have that data discussion with you. So I just want to let you know that. But we are all excited about the future of UV as it is becoming a little bit more mainstream, and all of this data will become available for everybody, which is very exciting. A little bit about just open operatory patients that are exposed. You guys all know this. I know this is what this whole event is about, really. But people that are coming into the environment are the biggest problem and the biggest reason that environments become not sterile anymore. I say this even in an OR environment. You can measure the air quality, go into a sterile OR and say there's no particles in this room and everything is good. But once you look at the surfaces and once people come in, all of a sudden now those numbers go out off the charts again. And this is where UV can come in to be a supplement to what you are already doing. So we are not changing any of this. We're not changing what you guys are currently doing. Say you're already wiping things down. This is kind of an either end of day or last step in between patients. So not changing any of that. This is just a really good visual for you to see like what Kirsten was talking about, those little particles that can move, especially in an open operatory environment, where they are moving from room to room. You guys are making it is a lot of aerosol generating procedures. And this is kind of the risk that runs in an open operatory environment. So by using a tower or different types of modalities, so even those air filters that just sit in the ceiling, we're able to constantly get the air particles, keep the environment as a variable out of the equation is really what we're trying to do. We're trying to eliminate the environment as a variable. Now, here's just a brief list of the most common organisms that we see, the most common organisms that you're probably going to see. I will say C. diff is another common one on here. C. auris is another common one, but I just didn't want to list it again because of the FDA regulations. However, if you have questions about more sport, or I suppose MDROs besides these, please reach out. Let me answer them. Let me put you in touch with our Office of Medical Affairs. Now, as just a very high level overview, this is just a really good visual that I like. We already kind of touched on it before, but UVC does not penetrate the ozone layer, so it does not make it down here to Earth, which is why when we expose a pathogen to UVC light wavelength, then it actually is breaking the RNA and DNA bonds of that pathogen, rendering it unable to replicate, which is why it is essentially becomes deactivated. The peak germicidal is actually 254 nanometers is what the majority of the data says, but anything in here is going to have some sort of germicidal effect. The peak germicidal is actually at 254. So all of our technology is created through mercury, a mercury bulb. There's less mercury than there are in your lights that are in the ceiling, so it's not anything to worry about being exposed to if the bulbs break or something like that. We're very safe and cautious about that, but that is how we produce it. It stays at 254 nanometers the whole time, so we're not moving anywhere around this. We're staying at that peak germicidal wavelength, and that's how it is actually we are delivering that dose of germicidal wavelength. Now, all of our claims and all of our data at Surfacide is what we call a 6-log reduction. For those of you who are familiar with it, essentially what that means is 99.9999% of all pathogens and bacteria in a certain area are going to be rendered deactivated. So when you hear Clorox wipes or somebody saying we kill 99.9% of all bacteria, while that's good, the truth of the matter is that it's actually leaving, 1,000 bacteria remain in that one area. Those 1,000 bacteria can continue to replicate, and that's how surfaces become contaminated. So by saying all of our data is this 6-log, this is what we are claiming for our use, and has been proven in all of that. This is what is being reviewed. Then this is what we're trying to get to. That one bacteria remains. Now we're able to say that is as close to a sterile environment as you can get it. Now, all of this does come down to the use and actual way that you implement this. So I see a lot of questions about, do operatories have to be isolated and sealed, and how do you use this in this kind of environment? I'm actually going to jump back up to this picture. So you see the light bulbs. If you are talking about the towers are rolled in, and they do have the effect to go 360 degrees, or we can actually just point them in one direction. So if you have an open operatory, you put them at the doorway, they shine into your room facing the other direction, then nobody's going to be exposed to it, and you don't need to worry about that. It can go in 360 degrees if you wanted it to. There is no shortage to usage and ways that we can program this. And we have tons of safety measures to make sure that nobody enters that room, that if they do, they shut off. It is really dependent on, from what I'm finding out about dental offices, which is different than a hospital setting, is that each one is very different. So if this is something that you are interested in, what I would do is come out to your facility, take a look at your operatories, see how it works, and come up with a plan that could work for you. And again, maybe that is, we look at ceilings, like ceiling light fans. Those you're not exposed to the light at all. It's actually tucked in there. The air just goes through, so it's constantly cycling the air. Keyboards is a separate thing. There's a ton of different usage for those. So just want you to know that there is no shortage of this. There's no shortage of ways that this can be used. Excuse me. We're actually in over 600 installations around the world now. Majority of them are hospitals, but dental facilities are becoming a very big focus for us, which is why I am here. So I believe that we are in over 40 practices now across the US, and that number is just growing and growing every single day. And what I can tell you is that every single one is different. So if you have specific questions about your facility, please reach out to me, and I'll have my information at the end here. This is one of our customers, Renew Dental out of Arizona, actually, and I pulled this straight off of their website. So a cool thing that they are actually doing here is trying to also make it a part of something that makes them different from any other customers in the area. So this is, here's what we're doing to protect our customers, our COVID-19 updates. They actually, if you can see, it's very small, I know, but in the back of this picture, they actually have their towers. They leave them in the room. So what they will do is a 5-minute wipe down, and then they will do a 2-minute cycle after the patient and doctors and anybody else has left the room, just in between patients. So sometimes I've heard a lot of other practices where they don't have that time in between patients. So this becomes an end of day practice. Where they're cleaning, they do their normal cleaning, and then at end of day they spend an extra 5-10 minutes per room running this in each room. Can be used in the lobbies as well. Again, just different safety protocols for each space, which I would go over with you. And then we do have this Dental Glow program, is kind of what we're calling it. So it is geared really towards whatever your facility needs. It's kind of a marketing piece, as well as the, if you will, the capital equipment that you need for your facility. So again, depending on what that is, if it is the lights, if it's the keyboards, if it's the towers, if it's a conjunction of all of them together, a combination of all of them together, then this is something that we would go over. Each of those things is really, the facility gets what it needs, the patient gets a good explanation of what you guys are doing. So we sort of arm you guys with a script, with the information about, here's what we're doing to take care of you as our patient. We're running this in between cycles. We give you some information. It's a very simple thing, a way that you can at least let your patients know. And then obviously we're taking into account the safety of your employees as well. And we're seeing that increased measures in workplace directly linked to employee motivation, engagement, because if they feel safe, they feel more taken care of, they feel like you're listening to them. We do all of this through a couple different marketing measures. So connecting it to Yelp, Google reviews, all of that stuff. We provide you with some marketing tools to be able to put it on your website, all of the things that you need. So we do have this program, and again, it's totally dependent on whatever works for your facility. And what we know here, and the reason that we've kind of shifted towards this, is just because even in a hospital healthcare space, it is a giant shift towards consumerism, towards patient loyalty, towards reviews from patients becoming a big part in where a patient goes. And I would argue in the dental space, it has been that for years and has become even more a part of that. So by giving you guys these tools to build this story of, here's what we're doing for safety, for taking care of you as our patient, then that perception becomes reality. And not to mention, you do have some pretty cool data to be able to support that. And so lastly, here is just my information. You can scan this QR code down in the bottom. It will link you to a landing page essentially that has my contact information as well. So you can reach out to me. I'm happy to talk with you specifically about your facility, any additional questions that you might have. But with that, please feel free to type them into the chat over here. I'm going to go back up and try to read some of these as long as I can. So I do want to let you know that UVC light is different than ozone. Ozone is actually a chemical. So UVC light is not a chemical. There's no chemicals being used in here. So after you turn off the lights, it is safe for you to walk in. So you're not being exposed to any ozone. It does smell a little bit, mostly because there is like fuzz and dust particles in the air that the light is interacting with. So it smells a little bit, but it's totally safe to breathe. People just say, and that smell will go away in literally, 10 to 15 seconds. So it's very different than, even a chemical smell, where you maybe need to give it some dry time afterwards. Let's see. Let's see. We keep air purifiers with UV light facing wall away, patient's view. Excellent. Yeah, that's great. I think that's, I see that. So somebody said we keep air purifiers with UV light facing well away from patient's view in each operatory besides the air conditioning ducts. What is your opinion of this space technology line? So I will say it's great that you're using that. The one challenge to the air things, especially if there's no fan that's going around it, and I should have made this a little bit more clear, so I'm actually going to go right back up here. UV technology is a direct line of sight technology, meaning that if it is not directly exposed to that light, meaning if it's in a shadowed area, if it's behind the light, something like that, it is not going to get that disinfection. Is not going to get that disinfection dose that you need. So it is a direct line of sight technology, and that's why we have our technology it goes floor to ceiling. It has reflectors and can rotate, so that we're trying to eliminate as many of those shadows and hitting your high touch surfaces as you can. So while that technology is really good, you want to make sure that you actually have the air cycling through by the light, because that's where it's going to be effective. OSHA protocol for UV technology, I have not seen, so I do not know the answer for it. I don't think that has been reviewed by OSHA yet, or at least given any protocols on that. So I don't have an answer for you on that. Again, for the safety of an open operatory setup, really it depends on the way that you want to use the technology and the operatory specific setup. So if you have a specific setup that you would like to talk about, I would be happy to go over it with you, because I've just seen there is so many different ways that you can use it. And yes, it is safe as long as you take the safety protocols, which is literally my job. So as long as you're not exposed to it, as long as somebody is not exposed to it and you set up the safety protocols correctly, it is very safe. I'm not sure. I just got a question, can it cause a zombie effect? And I'm not sure what that means. Not sure. Kill and then. So I don't know if you can a little bit maybe elaborate on that a little bit more. It would be very helpful. Do operatory rooms have to be isolated and sealed for these filters to work? So these are not if you're asking about the ceiling filters, they do not. So what that actually is essentially think about like your typical LED downlight that is in a room. That LED downlight sits and is normally in it. Above that, we have a concealed mercury bulb with fans on either side that are pulling in and circulating the air 24/7. That bulb is never exposed. It's very different than the LED downlight that comes down. So the air is being filtered in a totally concealed space. So it works totally fine and you would never be exposed to it. And it's just working 24/7, circulating the air. We see that one used a lot in dental practices, because along with your guys' ortho technology to keep the plume down, this is something that is constantly filtering the air and keeping anything that might be left over or sitting higher in the air, if you will, filtering through essentially above you while you don't have to do anything else. It just works 24/7. I see you have UV placed in the ductwork and is that the same? So if it is placed in like your HVAC, I will say it is essentially, yes, the same. However, we work with many HVAC companies who have said the HVAC that's working a little bit as an air purifier, but it should not be considered as actually keeping your air at a level that you want it to be for a dental practice or for a healthcare facility. Their HVAC really is for the maintaining the temperature and things like that of your space. It is not for purifying the air. So while it does have some germicidal effect, it is not going to be at the level that you want it to be at. What is the exposure time for UVC for hard surfaces? So the way that UVC works is if you will, the equation for it is time plus distance equals a dose. Okay, so time plus distance equals a dose, meaning the farther it is away, the light is away, the longer that you need to allow that light to shine on that surface for you to get that correct dose. Now, all of our claims for that 6 log reduction are within a 10-foot area. So we'll say within a 10-foot area, as long as it's not in a shadowed area, you'll be able to achieve that 6 log reduction. The time for it is what's going to change. So if you're within that 10-foot area, which most of your operatories are, and if they're smaller than that, even a 5-foot area, you're looking at 2 to 3 minutes. On the long end, you're looking from 5 to 7 minutes. And if you feel like there's a reason, if you have a patient that you know is COVID positive or something like that, maybe you want to give it a little bit more and give it 10 minutes. But it's going to be able to get that 6 log reduction in that timeline. Again, it just depends on the space that you have. And I saw, so using 2 to 3 minutes between pages is as effective as using it for 15 minutes. So again, it really depends on the space of it, but yes, 2 to 3 minutes, if you're using it in between patients, is really keeping the bio burden down, especially if you are already doing that. You're already doing your cleaning, your wiping, things like that. If you do it for 15 minutes, you're going to get an overabundance of light in that area. Things that are already deactivated are going to already be deactivated by that time. So as long as it's in a shadowed area, it's not like our light becomes stronger over time. Once a pathogen is exposed to it, then it is deactivating it. Now it just needs to get that correct dose. So the bigger the space, the longer you want to let it run. Let's see. Any other? I've already invested in a hospital grade air filtration systems in every room in the office. Is the UV process better or just different? So that actually, I would be curious what kind of air filtration they're doing. If it's like ozone or if they are doing, if it is UV in the air filtration. I think that probably those are just 2 different technologies. Like we said, ozone is a chemical that you don't want to breathe in. If there's a ton of other technologies out there as well, like foggers, things like that. Those are things you do not want to breathe in at all. UV is just a different type of disinfection. There is no shortage of disinfection technologies that are coming out right now. But if you take a look at it and want to discuss this further, please reach out to me. I'd be happy to hear about what kind of air filtration you have. This is available in California, absolutely. So even though I'm based out of Minnesota, I'm nationwide. Happy to come see any facility anywhere. That's my job. I would love to come see your facility and talk you through it. I see another hypochlorous acid sprayer to disinfect each operatory. There is no concern using UV light after that. There is none. So the nice thing about UV is there's no interaction between chemicals and the light wavelength. It really is just between pathogens. So there is no concern about that. The nice thing is that there's no waiting period after UV. So, if you want to do your spray and then UV at the same time, you are welcome to do that. Okay, good. So I saw the air purifier has 3 speeds along with UV light. So that's great. Honestly, that's a great way that it's bringing the air in. It's bringing it right over the light. That's exactly what you would want to see. And essentially that's what our ceiling ones do as well. So I think that that's a really good solution that you found. The safe distance from the light. So we do not want to be exposed in front of this light, no matter the distance. So this is something where we need to be standing behind it, be in a shadowed area, around the wall, something like that, behind a door. The nice thing is that I will say UV does not go through glass. So if you have glass windows or things like that, you're not going to be exposed to it if you're standing on the other side. But if you are in direct line of sight from it, there's no safe distance. We would not want you standing there. Is there a type of viral or bacterial kill that can reactivate? Thank you for it. That's on the zombie question. I appreciate you explaining that further. I do not know of any. No, I have not heard of any that have been reactivated. Once those DNA and RNA bonds are broken, they are no longer able to replicate. So it is rendering them unable to replicate, which is where really colonization starts happening. So I have not heard of any that are reactivating or able to do that. Yes, the cost for this type of UV technology is, it really depends on what you are using it for and how, like, what your needs are. So we have this GLOW program ranges dependent on what you need and the payment plans and financing options that you would like to do. I honestly would love to hear more about your facility and kind of talk about what you are needing. You saw in the end of that video, there was as low as $20 a day. So that's kind of, I would say, on the low end, but again, we have rental programs, we have financing options. So I would love to hear a little bit about your facility, and we can dive into that. The approach of academic clinical areas. So let me see. It is available in Canada as well. I think that was the last question. We are a global company. We are available anywhere in the world, have a huge presence in Canada, Mexico, the Middle East, Africa, Asia, all over. So yes, absolutely. And what is the approach for academic clinical areas? I'm trying to, whoever that is, if you want to, can you elaborate a little bit more on what you mean by the approach? We do work with a number of academic institutions. The Ohio State is our main academic institution and has provided the majority of our data. University of Iowa is as well. So I think that we love to work with academic clinical areas. If that's something you're interested in, I would love to discuss that further with you. I'm trying to think if there's any other questions. I hope that I was able to answer some of your questions on UV and give you guys a little bit more insight. What I hope you take away from this more so than anything is that I have come to realize how vastly different every dental facility practice is run and is laid out. And that is where I would love to come in, work with you, and find a solution that works for your practice to help keep your staff and your patient really, really healthy, especially now that we're all going through a new and different kind of with RSV and, COVID still going around and all of the above. So, we want to be here to be a solution and work with you guys.
Thank you, Danny. I wanted to let them know that we do have your handout. It is available for them, so they can address that by going into the public chat area, and they'll see a link, and it's to a folder. So it includes your presentation today, your information. They can reach out to you directly.
Awesome. Thank you. I appreciate it. Thank you guys all for your time.
Thanks, Danny. I appreciate it. Thank you to Surfacide. And this will be available for recording as well. All right. Okay, everyone, we're going to go ahead and close. You are going to receive an email from us. You'll also be directed to a screen to complete a brief quiz for CE credit. And be sure to check your email it'll say thank you for attending from noreply@clickmeeting.com. The next course that is up is Dr. Deborah Goff at 12 o'clock Pacific time, 12 to 1:30. This is not a webinar that you want to miss. This is the new antibiotic guidance. She is also from the Ohio State and an international lecturer on antibiotic stewardship. A lot of the questions that you had during my C. diff course are questions that can be addressed during her presentation. She'll do a deep dive. So be on the lookout for that registration link. If you've not registered, go to the website. It's also in the instructions, and you'll see her 12 o'clock presentation. Thanks everyone so much for being here, and we'll see you in about an hour.